Good morning, everyone. I forgot to unmute myself. It's just 9 o'clock. I'm going to wait for a moment and see if anyone joins me. Otherwise, I will just get started answering questions, and you guys will all see this on the video when it's posted. Just looking through, we have some really good questions today, as usual. I'm always interested in what you guys are asking, and I think that a lot of this stuff is these are answers that apply to a lot of people, and a lot of people have on their minds and things like that. So it's going to be useful not just for the people who ask the questions, but for other people listening as well. Okay, so let's get started. My printer is going in the background. Hopefully that's not making too much noise for you guys. The first few questions come from one of my clients, my coaching clients, Catherine, and they're all kind of related to each other. So we'll start with her questions. She says, I recently had a failed FET. Implantation happened, but it was barely a chemical pregnancy. A year ago, I had a natural miscarriage at 10 weeks. So far, all of my diagnostics have come back clean except a positive BCL6 receptiva marker. What do you recommend as next steps before another transfer? I have a hysteroscopy scheduled to take care of any potential adhesions and scarring, and I'm considering scheduling a laparoscopy for potential endometriosis. The next question folds into this. She says, how will I know when I need to start exploring potential autoimmune factors for failed sustained implantation? I did a few initial screens that came back clean, but I worry that there might be more issues hiding. It all feels very overwhelming. What are the first steps down this path? So one thing I will say is that the speed with which you act, the steps that you take, the order that they go in, how much money and time you spend on this, it is going to vary from person to person for a few practical reasons that it's just good to sort of talk about right out of the gate. If this is your first failed transfer, you know, it's not your first loss because you've already had this miscarriage previously, but if it is your first failed transfer and you have a good number of embryos, what does a good number of embryos mean? That's also different for different people. If we're talking blasts that are tested euploid, how many children do you want to conceive? If you want to conceive one more child, maybe a good number of blasts that are, tested might be, with a history of miscarriage, might be 2 to 4, right? If you had a very hard time making those blasts, if you did multiple rounds and did lots of testing and had lots of embryos that came back abnormal, or you had very few embryos to test, and you... Hi, Catherine. I'm just starting to answer your question. If you have had a harder time making those embryos, then while every single embryo is always precious, that is always my stance, always my belief. How many embryos you have, how many children you want, and how easy it was to make those embryos factors into how precious they are in terms of the steps that you take. My goal certainly is to avoid all miscarriages that can be avoided. Any miscarriage, we want to do everything we can to avoid it, but going down the path of treating endometriosis, going down the path of seeing a reproductive immunologist is complicated, time consuming, and expensive. So we do factor in some of these things. If you are talking about embryos that are not tested, then I think we probably want a higher number. If we want a lot of children, if we only want one child more or one child total, then you can potentially have a smaller number of embryos, not just because you're only interested in one child, but because if you don't have a successful pregnancy or transfer, you could potentially switch back over, making embryos, make another 1 or 2 embryos, then switch back to transferring, etc. So I do think you have to put that math and that feeling into it, that decision making. And then, of course, you have to do what's right for you, right? Like, you're in the driver's seat, even though it generally doesn't feel that way. It mostly feels like you don't have any power. All of the things that we offer, my services, AIMEE'S services, the information that we have, the groups that we have that you can join, the diet recommendations, the supplement recommendations, the doctor recommendations, the things that the doctors have to offer, the IVF and IUI and medications and surgeries and everything. All of these are the tools in your toolbox, and you are the one who decides when you need to pick them up and use them. Of course, we're here to help you understand when it's right to do those things for you. But there will be some women who want to move faster and some women who want to move slower. And that will be not just based on sort of facts and putting together, you know, a package of information that statistically applies to everyone. Some of it will be about how you feel, what your gut tells you about what's going on in your body, or how deeply you've been hurt by the losses that you had, and how much it is important to you to do everything you can to avoid another, right? Having a positive BCL6 marker, which is the protein that they test for on that Receptiva test. Receptiva is a test that's done with an little biopsy sample from your endometrial lining. That Receptiva test is a test that I always say can rule endometriosis in, but it can't rule it out. It's not considered a diagnostic test. The only diagnostic test that absolutely definitively confirms endometriosis is a laparoscopic surgery to remove it, or in the case of a woman who has endometriomas, which are little growths, usually on the ovaries, occasionally I think on the fallopian tubes also. If they take a sample of the endometrioma, they can test that and they can confirm that it's endometriosis, but also just the mere fact that it's there, almost 100% means that it is endometriosis. But other than those two ways of testing, nothing is 100%. So Receptiva came on the market a few years ago, and there's been a lot of resistance to it up until very recently. A lot of doctors saying, oh, I don't do this test. Oh, this test is unreliable. Oh, this test doesn't tell us anything. Oh, that's just a waste of time. However, in the last few months, that has sort of changed, at least with some doctors. And now it is, I would say, generally understood that if you have the positive result on the Receptiva test, if you are positive for the BCL6, that is an 85% chance that you have endometriosis. So now we are starting to see, I think, a few more doctors run the test, and we are starting to see doctors take the results of the test more seriously. So I would say that given that you have what I consider 2 miscarriages, you know, we're using lots of different words to talk about the same thing, but you have 2 pregnancies that didn't continue. And you have the positive Receptiva, I would say that I strongly consider you to have endometriosis. I'm sorry. So there are 2 things that you can do about the endo. I think having the hysteroscopy scheduled is a good idea. Having had the losses, we do want to see if there's anything going on structurally inside your uterus. That can include scar tissue. It can include polyps, adhesions. It can include structural things that are about the way that your uterus formed when you were born or when you were made. So there can be little membranes called septums, or there can be kind of an abnormality in the shape. Most of these things don't interfere with pregnancy in the larger sense, but having a hysteroscopy and having any of them that can be addressed in that hysteroscopy addressed improves your chances of a successful pregnancy. But the endometriosis comes it really comes down to two things. So 85% chance is a pretty high chance. The receptiva, just to go back to that for 1 second, it can be negative and you can still have endometriosis. That's why I say it can rule it in, but it can't rule it out. So the best information that we get from it is when it is positive. It tells us that there's an 85% chance of endo. If it's negative, it doesn't tell us one way or the other, is there or is there not. We don't have any additional information there. There still could be endo. So with endometriosis, the longest term solution is a laparoscopic surgery. So they go in, they make several incisions on your belly, and they go in through those little incisions and they look for and then remove the tissue if they find it. And I have to say, I've never had anyone who scheduled a lap who didn't have endo to find. Some people who have no symptoms at all and have never had any symptoms have very aggressive, very severe endometriosis. Some people who have a lot of symptoms have fairly minor endometriosis, and everything in between. It's not well enough understood kind of why people can have it and have no symptoms, why other people can have really severe symptoms. We're still working on it, and probably not fast enough. So if they do a laparoscopic surgery, the benefit of that is that the tissue is removed. The ability for the tissue to grow is not removed, so you still have endometriosis, you just don't have the tissue in you. It's going to grow back, and it grows in response to estrogen. So all the things you're doing in order to make embryos and to get pregnant and to have a healthy pregnancy, and breastfeed and everything are things that support the endo growing again. So it is likely to come back. The speed with which it comes back is unclear, but a laparoscopic surgery, I would say that sort of like a rule of thumb or a hope is that you could have 2 children before you might need to consider another surgery, unless you have a really extreme case. So you could have the surgery, have a healthy pregnancy, breastfeed for a time, get your period back, have another healthy pregnancy, and hopefully that would be all okay with that one surgery. You wouldn't need another. Sorry, something fell out of my printer. That doesn't always happen. Sometimes people need a repeat lap in really extreme cases, but in most cases, I'd say that's true. Anyone who has symptoms, so they have pain during sex, they have pelvic pain, they have pain that feels like regular UTIs, that's usually called interstitial cystitis. If they have really severe menstrual pain, if they have any of these symptoms, then the laparoscopic surgery is also a more appropriate treatment in most cases, because it will resolve those symptoms for a longer time. And so some people won't ever need to have it again. Some people will need to repeat it in 5 years. Some people will repeat it in 10 years or longer. It's very different from person to person, but it has the longest effect. So if you are hoping to have more than one child, it is the thing to consider. It has maybe a 6-week minimum kind of physical healing that happens afterwards, where you're definitely not trying to get pregnant. That can be longer for some people. And then you may not immediately do a transfer exactly 6 weeks after, even if everything goes really well, because there may be some additional prep that needs to happen before you can do a transfer. But it has a recovery period, but it's not a 6 or 8 month recovery period. It's in keeping with some other things. So the other thing that you can do to treat endometriosis is you can use medication. So the primary medication that has been used for the longest time is something called Depo-Lupron. It is the same drug, Lupron, that is used in some of your IVF cycles, but it's given in a different dose and in a different method. what giving a high dose of Depo-Lupron does, it's an injection that is administered in the doctor's office. It's typically given for 2 or 3 months, meaning you go in and you have an injection, then a month later you go in and you have another injection, and then possibly another month later you go in and have another injection. It shuts off your body's estrogen. So some people will refer to this as putting you into menopause. I think that's not a very helpful way to talk about it. It's much better, I think, to talk about it in the actual like biological terms, that it shuts off production of estrogen, because people understandably get really, really upset about the idea of menopause, right? Believe me, I get it. Even if you're not actively trying to have a baby, it's not something anybody wants, right? At this stage in our lives. So it does cut off estrogen, and what that does is that it starves the endometriosis tissue and it withers away. And I always think in visual metaphors, because that's how my brain works. It's like winter comes, and the endometriosis is still there. You still have it, just like if you have a laparoscopic surgery, your diagnosis is still endometriosis. Instead of having had it cut out at the roots and maybe like the stalk structure, if you're thinking of trees, is there, but it's almost dead. It has no leaves, it has no green growth, it's not moving and growing and changing. It is hibernating and withering away and being negatively impacted, kind of like impaired by the lack of estrogen. When the treatment is over, your body will eventually start to make its own estrogen. Typically, it's in the following month. So if you have 2 months of this treatment, then you get a period in the 3rd month. If you have 3 months, you get a period in the 4th month. Exactly how fast it happens for each person is a little bit different. But your body is no longer being suppressed by this massive dose of Lupron, and so it starts to make estrogen, and then your cycle turns back on, and it starts to move through all the normal things like developing a follicle, ovulating, progressing to a period if you're not pregnant, etc. And that's when you start prepping for a transfer. And you can do multiple transfers if the transfers are not successful without having to repeat the Depo-Lupron treatment. So this treatment is sometimes given for symptoms also, and it is said to have something like a 6 to 18 month effectiveness period. So I think you can think of it in the like 6 to 12 months, right? And for some people, having estrogen pumping through the body again is going to affect the growth of the endometriosis very quickly. And for some people, it's going to go very slowly. It sort of depends. There is another drug that they can use called Oralisa, and they can do a slightly modified, maybe like lighter version of this Depo-Lupron treatment for some patients who have more minor endometriosis. It still takes 6 weeks to 8 weeks, like it's not really short. So this treatment for endometriosis, regardless of which direction you go, is definitely a pause for like 2 to 3 months, right? Before you start prepping for a transfer. Again, no matter which path you go. And there is another condition called adenomyosis. So endometriosis is growth of endometrial lining tissue outside of the uterus. Adenomyosis or adenomyosis is it's growth of endometrial lining tissue kind of like through the wall of the uterus. So this should be visible to someone who knows what they're looking for, not an ultrasound tech who runs like ultrasounds in a IVF clinic where they're just looking at the lining and just looking at the follicle size. But a doctor who specializes in endometriosis and adenomyosis. This should be visible to them on probably a saline sonogram or sometimes on a hysteroscopy. And what it does is it affects the lining of the uterus. So where the endometrial lining tissue is growing like through the walls, there is a lack of lush, thick, healthy, moist you know, growing lining tissue. So you get patches in your lining. And depending upon how many there are, how big they are, so like how extensive the adenomyosis is, and depending upon their location, they can impede implantation and stop pregnancy as well. So if the girl also has adenomyosis, because adeno and endo go hand in hand, and adeno has a very clear role in implantation problems, then I believe they need to add letrozole treatment to the depo-Lupron. So while you're on the Lupron, you're also on another drug called letrozole. And if you have the adenomyosis, even if you have the laparoscopic surgery for if you have the adenomyosis, even if you have the laparoscopic surgery for endometriosis, you still have to have the medication treatment, the depo-Lupron and letrozole, or Lisa and letrozole for the adenomyosis, unless it's a really small amount of it and it's really in an area where they don't think it's going to impede the implantation. And then that also becomes a little bit of a judgment call on your part, going back to what I said in the beginning about how many losses you have experienced, how those losses have hit you, how you feel about the potential for trying again and not having treated it, and what that could mean. And also the number of embryos you have available, how easy it was to make them, and how many children you want. So if you have a very small number of embryos, I would probably do the treatment even if the doctors really feel like there's no possible way that this tiny patch of adenomyosis is the problem. If I have one embryo, I'm still going to want to do the treatment before I transfer that embryo. So because you, Catherine, have the positive receptiva, and because that is now accepted to be about an 85% chance of endo, and because you've had the 2 pregnancies that didn't continue, I think that you should be talking to someone about either of these treatments. And you should be, at the very least, strongly considering it, and probably undergoing one of these treatments. If you have a large number of embryos and they've been fairly easy to come by, if you want to try to do one more transfer before you do it, because it's such a big step, that's definitely something you could consider, but I would not do more than one, even with a large number of embryos. So there are 2 surgeons that I really love here in the US. One is Dr. Vidali in New York. The other, I don't know if I pronounce his name correctly. I pronounce it just by like reading the letters. I say Kongoasa. It's Kongoasa. And he's outside of Atlanta. They're both great surgeons. They both are very fertility focused. They both understand not just the surgical implications of the work, but also the next step after surgery as you're prepping for a transfer, which is the big question of what, if anything, in addition to surgery or in addition to suppression, does this person need in order to have a successful pregnancy? And that's where we get into the second question that Catherine had, which is, how will I know when I need to start exploring potential autoimmune factors? I did some initial screens that came back clear, but I'm worried if this feels very overwhelming. What are the first steps down this path? So this applies to people who don't have any indications of endometriosis or adenomyosis, as well as people who do. The field of reproductive endocrinology, which many or most of you are well experienced in, is the fertility clinic world. And there are some great doctors there, and they do amazing things, and we depend upon them, and we appreciate them, and they are really good for us. But they are highly specialized, and so the specialty that they work in is making embryos and creating pregnancies. Right? That's what they specialize in. They don't specialize in the environment of the woman's body that is the host to the pregnancy, that is enabling, that is the universe, that is the environment that needs to accept, allow, and support that pregnancy. Now, over the years, a different specialty has evolved, which is called reproductive immunology. Reproductive immunology is much smaller, much less widely used. Also, it's been around for decades, but sometimes doctors talk about it in very negative terms because a lot of what's done in the field of reproductive immunology is not FDA approved, and the testing that has been done on really small numbers of people. And that's because it is a small field and there are fewer people that know about it, and there are fewer people that can afford it. And so there are fewer doctors who practice it. So there are just fewer people that have been going through it, but it has been around for decades. So it isn't new. It is more cutting edge. It is also incredibly expensive, time consuming, and aggressive. So I also love it the same way that I love the reproductive endocrinologist. I love what it can do for us. I love the support it provides for us. It is not necessary for everyone. And this question, what do you do to figure out how much of it you need, who you should be seeing, how you should be investing in it, whether you need it or not? So one thing I would do is, in the case of endometriosis, if you are considering surgery, I would choose your surgeon carefully if you can. The two that I just mentioned, Vidali and Kangawasa, if that's how you pronounce his name, you can speak to them about additional support, what their thoughts are, what testing they think you should have additionally, what type of medication support, if you should pursue reproductive immunology in addition to surgery. They're not reproductive immunologists. They don't practice that. They can't do that for you, but they work with a lot of people who do it. And Vidali worked before it closed at the Braverman Institute for Reproductive Immunology here in New York for many, many years. So they know what they're talking about there, and they are good sounding boards. There are not that many doctors, but there are more and more all the time that do this. So in the US, I have a short list of people. Outside of the US, there's a shorter list of people, but there are some people in Sydney. There's at least one person in London. There is a practice we've recently just found out about in Spain, I think, and then in Europe, Greece and Crete is kind of where most of this is happening. There's also some stuff happening in Eastern Europe. I think I don't think it's Bulgaria. It might be Albania, which is, I'm not sure if that counts as Eastern Europe fully. But that's how I think of it. Anyway, there are some other places popping up. If you're my client, email me and I'm happy to email you some of this information. If you are Heather's client or Amy's client, you can email them and ask for it. We also have some resources on the website where we look for recommended practitioners, and there will be some information there about reproductive immunology as well. So you can just go to a reproductive immunologist. There's probably a 6 to 8 to 12 plus week wait to get an appointment. Depends on the doctor, depends on how busy they are at a particular time. You're not going to get in with them immediately. You're also going to need to do a whole bunch of tests before your actual appointment with the doctor. So on one hand, that's really great because you don't have to figure out what types of tests you need to do. You don't have to find a doctor who is willing to do them for you. You go to, for instance, Dr. Kwok Kim in Chicago or Dr. Durbala in Detroit. And they know what they want everyone that they see to have tested. And so they set about sending you for all of these tests. Most of what they do is not covered by insurance. So you're going to be paying out of pocket for most of it. So you're going to pay a lot of money to do a lot of tests before you see a doctor. And then the answer could be, I don't think you need me, which is frustrating, but actually kind of great, right? Because the fewer problems we have, the better. And they are big experts in this, and they do have you do a lot of testing. So if you have a lot of money and you have a lot of time and you want to simplify everything down and like not be getting test results and then looking for doctors, this is definitely the straightforward path to take. And these are great doctors. I mean, the two I just named, Dr. Kwok Kim in Chicago is amazing. She has no good website. There's practically no information about her online, but she's fantastic. And she's been doing this for a really long time, and I really, really trust her. Dr. Derbala in Detroit is the first person that she trained who's out practicing on his own. He's also been practicing for years, and I really trust him, and he does a great job. She has trained some other people who are out in the world. There's a guy in Florida. I can't pronounce his name for sure either. It's spelled Jubiz, Jubiz, but I think it's pronounced Ubies. So he's also very good. Like there are doctors. The original doctor who kind of invented all of this is Dr. Alan Beer, and he's in the Bay Area. So that's the most straightforward path. Go see a reproductive immunologist. If you don't want to do that, if it's too long to see someone, if you're uncertain about whether you need this and you have to conserve your resources and you can't just spend money on things that you might need, you have to really know that you need it, then you want to try to do some testing first. And if that testing indicates that you need the treatment, then you start contacting the doctors. And in general, they're not going to make you repeat tests that you have done as long as they're comparable to the tests that they do. So you won't be usually, I can't promise, but usually I don't expect you to be spending the money twice for all of the testing. There will be some testing that they still want you to do, even if you've done some testing in advance on your own. So there is a test called Pregmune, P-R-E-G, Pregmune, M-U-N-E, like pregnancy immune. And it was put together by the Braverman Center, and even though they have closed, Pregmune is still around. And it is the closest to exactly what you would get from any of the reproductive immunologists. The trick with Pregmune is that you have to have your doctor refer you in order to do Pregmune, and then I believe they have to like order the tests. So your doctor has to be willing to do it. So some reproductive endocrinologists will be open to this, especially if you have like the Receptiva test positive, and they'll say, yes, I'll sign off on the Pregmune. Some will not, and everything in between. So it is certainly a path that you can go down. It is certainly a great set of tests that you can do. And if you are in a situation where you have the right doctor, it can work really well. The testing will be similar to how it would be with any other doctor. Anything that your insurance will cover can be covered. And then any of the stuff that is not covered by your insurance, you'll be paying for on your own. So it's kind of like a blended out-of-pocket expensive thing, but with a little bit of insurance coverage. And then when you get the Pregmune results back, if you have a coach, we can, share it with me. If I'm your coach, we'll have a meeting, a session, we'll go through it, we'll talk about it, what it all means, etc. And because it's not attached to a reproductive immunologist, you, depending upon your doctor, usually a reproductive endocrinologist, you may be able to address the results just through your reproductive endocrinologist, because the results may be minimal, the recommendations may be minor, the reproductive endocrinologist may be comfortable in that space, or you may not be able to do that with your reproductive endocrinologist. And that's the fear that they have, why some of them won't recommend it or sign off on it, refer for it, etc. And also, as I always say, don't blame the individual doctor. In general, most of them are working for a practice that's owned by someone other than them, and they have to work within the guidelines that the bureaucracy of the practice has set out. And so it may not be up to your specific doctor. They might have a rule that they just don't do this, right? And then your doctor's hands are tied. They're not going to tell you that. So it's going to be a little unclear to you, but bureaucracy, can really squash this stuff. So another opportunity, another option which is entirely out of pocket, is to do some testing through the company Fertilysys, Fertilysys. They are based in Greece. That's why there's no insurance coverage. You don't need a doctor to sign off on everything, but there will be some blood tests. So you are going to have to get some blood tests drawn. They do you select the tests yourself, and they come in like groups, right? So like a test has a name, but it's actually a whole lot of tests. And if you have a coach, we can help you figure out which of these tests you need to do, but they also have good customer service, and you can talk to them about what you're trying to test for. And some of the tests groupings should make a lot of sense. Like there's an inflammation index, and there's a panel that's all about blood clotting, and they talk about immunology in another panel name. So like it is something where you can get guidance on selecting which tests to do. Some of them will be blood tests, some of them will be menstrual blood self-collection tests. You can do these tests, and then depending upon the results, you can take them to your doctor and ask them to address them. If you're coaching with one of us, sometimes we can address some of those results with like herbs and other things, other supplements. You may determine after seeing these results that you need to see a reproductive immunologist, and then you can start down that path. So there are ways that you can look into these things. We also have a list, which if you're coaching with me, I can email you. I probably have emailed you before. We also, I think it's on the website. I don't know exactly where it is, but it is a long list. It's broken into two categories. One category is blood clotting, and the other category is inflammatory markers like autoimmune markers. Most doctors won't run every single test on our list, but you can take our list to your doctor and ask them to run these tests, and you can compare the list against the tests that you have had done if you've already had some testing done, and see what comes up. So these are the ways to get into this and assess what you need. And I'm just going to give like a really brief kind of like intro into sort of like what happens next. Like, let's say enough tests come back positive that you need this kind of support in order to maintain a healthy pregnancy. I used to talk about the treatment in terms of like a three-legged stool, because of course I'm a very visual metaphor person, but actually it's kind of like a 4 or 5 or 6 leg stool at this point. So one leg of this stool is definitely blood clotting and blood flow. So anybody who has risk factors for endometriosis, as long as they don't have like an allergy to it or a bleeding disorder, should probably be taking a low dose aspirin from ovulation or transfer on, and continuing into pregnancy. If you're not pregnant, you can stop it and then start again the next ovulation or transfer that you could conceive. If you have a lot of blood clotting factor issues, or some of them are homozygous, meaning they're genetic, you have 2 copies, one from each of your parents, then low dose aspirin is not going to be sufficient, and they will put you on an injected blood thinner. The name in the US is typically Lovenox, and in the UK, not the UK, Europe and I think also Australia, I think it's usually called Clexane. And it's scary sounding and it is serious, but there are hordes of women who do it throughout their pregnancies. Some only need to do it for like the first trimester. Many need to do it all the way through the pregnancy. So that's kind of like one aspect of this. Another aspect is immune suppression. If your body goes into like a flare of overactive immune function within your uterus when an embryo is introduced and starts to implant, it will stop the implantation process and stop the pregnancy from occurring, because it is treating the embryo as a foreign body that is there to cause disease, right? I always say a man's immune system is incredibly simple compared to a woman's, because it only has to make one distinction. Is this thing me or is this thing not me? And if it's not me, let's kill it. A woman's immune system is much more complicated, and this is why women have way more autoimmune conditions, because a woman's system, in addition to identifying things that are not me and are bad and need to be killed, also has to allow for a period of time when something that's not me lives inside my body, and I support it and allow it to be there and allow it to flourish, because it's not a disease, it's a baby, right? And once there's a placenta in place, which is around week 10, 11, 12 of pregnancy, that is fairly easy for the vast majority of immune systems, although obviously there are some exceptions. There's some women whose immune systems are still struggling at that point. But there's an organ in place, and there's a separation between what's the woman and what's the baby. And the body understands that. We have a lot of organs, right? We have a lot of things that do functions in our body. And so the immune system can kind of be like, oh yeah, got it. That's this organ doing this thing, and I'm like not fighting it. But until that point, right? Until week 10, 11, 12, it's not protected in that way. The pregnancy. I mean, at the very beginning, it has to be entirely exposed and implant so that the beginnings of that placenta can start to form in the uterus. And that's when the immune system can go really haywire and can end the pregnancy. So if your immune system is acting that way, and that's what a lot of the tests are trying to find indications of, although sometimes you will test like normal on these tests unless you're pregnant. People's numbers change during pregnancy because you might not have an actual identified autoimmune disease that like has flares. You know, if you had rheumatoid arthritis and you had a flare, you would be having pain. If you had Crohn's disease and you had a flare, you would be having like diarrhea and blood in your stools and pain. But maybe you don't have that. Maybe the only autoimmune thing that you have going on is what happens in your uterus when there's a pregnancy. When you're not pregnant and you haven't had a loss in the last few weeks, your markers will potentially test totally normal. But once you're pregnant, some of those markers will change. So that's why this is a nuanced game, nuanced field, right? So blood circulation support, blood clotting support, immune suppression to stop that like flare activity. Then also there can be immune support in order to kind of like chill out the immune system. You kind of feed it certain things that make it happy and make it feel calm. I'm not going to go into a bigger discussion of that here because I want to get to all the other questions too. And then there's also another leg that is about like blood sugar and metabolic support, because again, I'm not going into a lot of detail here, but like the way that I tend to think about the reason why we pay attention to blood sugar and insulin and metabolic function is that when your blood sugar is high, even just like a little high, it's kind of like having systemic inflammation. It's kind of like having, you know, all the wiring in your house is just a little hot because you're running just a little too many things through the system. And it's not on fire, but if there's a fire that starts up somewhere else in the house, the fact that the whole place is already hot is definitely going to be an additional complication that makes things worse. So that's just like a little bit about what would happen next. This is a lot of information, but I do think that this information is a lot of people are wondering about this. So that's why I've taken the majority of this session to talk about it. So now we're going to talk about the egg quality diet. So Catherine has a question about this, and then Sarah has a question about this also. So Catherine, you say, I've been doing the egg quality diet since all these procedures will take a few months. I'm considering taking a break, trying to decide how far to back off, especially that we're going into the holiday season. Is there anything that's critical to maintain over the next few months? How long before my next transfer should I get serious about the diet again, hoping to do a transfer in January or February? So the goal of the egg quality diet is not really for you to go off it at any point in time, which I know sucks to hear, right? The goal of the egg quality diet is to slowly reintroduce all the foods and learn which foods you don't tolerate well, and then to not eat those foods that you don't tolerate well, you know, in theory ever, but depending upon your reaction to them and depending upon the circumstances, we would say like there will occasionally be reasons why you, or times when you do eat them. And so you each have to make a decision based on how far you've gotten through the diet, how much you've reintroduced, how well you've responded to the things that you've reintroduced, how complete your diet is, what you are going to do when there is a holiday or a vacation, or when there's a super busy time when you know you're going to have less time to cook, because that kind of like goes into Sarah's question. So I'm just going to read that and then talk more about the egg quality diet altogether. She says, I just bought the egg quality diet book. And since everything is so specific with meals planned, are there ways to follow it with tweaks to it? My husband is very picky about food and we do share cooking throughout the week for dinner. So I'm worried that it will become a struggle. In addition to that, I'm trying to find a balance, having time in the morning to prepare breakfast before leaving for work, to give myself enough time and not have to rush, etc. So, the whole thing is designed in phases, right? Phase 1 is the preparation and it should go fairly quickly. Phase 2 is the worst, most strict part, but it's only 11 days. Phase 3, you have really reintroduced all fruits and vegetables, all animal proteins, and not much else. So if you are in phase 3, it can really, really feel like it's super restricted. If you get into phase 4, now you start reintroducing. And I usually suggest that people start with something like nuts and seeds, because they have a different texture and they lend themselves to snacking, and they have good protein and fat and so on and so forth. But you're going to make your way through literally all the foods, unless you know that like when you eat strawberries or when you eat eggs, you're allergic to them and you have a bad reaction. You're never going to reintroduce those foods. But the goal at the end of it is to have reintroduced everything and know about everything, and then to eat a diet that's made up of the foods that support your body well. And then if you have holidays come up or a trip to Italy or whatever, you may not only eat the foods that you have learned through the diet are the ones that support your body the best. You may also eat some of the foods that your body doesn't respond to very well. The goal is to eat them minimally, right? So like you eat them on Christmas, or you eat them on Christmas Eve, or you eat them at, your anniversary, or you eat them for the week that you're in Italy, right? We're not just necessarily talking about one meal. And then you go straight back to eating the late phase 4 you've reintroduced lots of foods and you know about lots of things, way that you normally eat. So my recommendation is anything that you respond badly to, that you have a reaction to, you really should not be planning to eat, especially while you're still trying to have babies. If you eat it in certain circumstances, like at a particular meal or on a particular trip, in a week where there's just a million holiday events, recognize that that's not a change in your diet. That's not that you have stopped the egg quality diet. That's not you have quit doing it. It's not that you no longer do it. Don't use any of that terminology. Instead, say that you are making an exception for these meals or these days for these reasons, and that that that's an exception that has a finite amount of time, and that after it's over, you're going to go back to only eating the foods that support your body well. So that's my recommendation. Sarah, I would say that husbands can't eat the egg quality diet exactly the way that it's written. Even some women can't eat the egg quality diet exactly the way that's written, because we are all different. I have a client who has an autoimmune condition and it's in remission, but she's had it for a long time. She's also very small, and she loses weight very quickly. And the egg quality diet, she just did the reboot and she tried to follow it exactly, and she lost weight really quickly. And that brought on a flare, very small, but a flare of some of her symptoms. And so even something that is good isn't always equally good for everyone. The egg quality diet as it is written is going to be good for the vast majority of women, right? So it's okay that it's written the way that it is, because the majority of people that read it and follow it are going to benefit from it. And the foods themselves that we recommend eating are good for you. There's nothing wrong with the foods. Any food that you're allergic to, obviously you don't eat. Any food that you discover you have a reaction to, a response to, you don't eat. But that's the purpose of the egg quality diet, to learn and find those things. The foods themselves are not, there's nothing harmful about them. But how you implement it may have to be different for different people. And for men, they need more calories, they need more carbs, they just do. So you can't have him eat it exactly the way that it's written. Like, he's always going to need an extra carb. He's always going to potentially need more food. So if you are doing the egg quality diet, and the main meal that you're worried about is dinner, because that's the one that you and he switch off cooking, I would try to use the egg quality diet as a cookbook. So you can look through the recipes that it provides and pick out ones that look like the two of you would both be okay with eating them for dinner. And then those could be the recipes that you cook. You could theoretically cook those recipes and also cook something else to go along with them, so that he has more food in addition to what you eat. Or you could have a smaller portion of that. Let's say it's rice or quinoa or something like that. So I would use it as a cookbook. Same thing with the breakfasts and like speed. There are a lot of smoothies, none of which are these like icy, fruity, you know, kind of like yummy treat type smoothies, although they have yummy things in them. And once you've reintroduced fruit, they have fruit in them. You want to be careful about eating too much fruit, because it will throw off your macros and be higher carb. But there are a lot of smoothies in the book and in the additional resources that go along with the book. And so smoothies can be something that people eat in the morning. You can also, it's not in the book, but the only way that I think eggs taste good cooked in advance, because they really only taste good cooked fresh, is in like the equivalent of a frittata. And you can do little muffin cup frittatas. You know, you could do a little 6 muffin cup pan of frittatas. And you could put vegetables and, you know, all kinds of things in them. And then you could eat the equivalent of like 3 eggs or 4 eggs, something like that, in frittatas, you know, on Tuesday, Wednesday, Thursday, something like that, having made them on Monday or Sunday. They will last a few days and they usually taste okay. You know, no eggs otherwise really taste okay unless they're fresh cooked. So you can use cooking techniques for other things that you normally eat in the morning for a fast breakfast, but change the ingredients that are in them in order to be in compliance with the stage that you're at in the egg quality diet. And when I have a client who is really resistant to doing the egg quality diet, or is really afraid of doing it, or has a particular reason why it's going to be a very big struggle for them, I generally say start out by using it as a cookbook, you know, and then let's progress from there. So next question, also from Sarah: with the potential of endometriosis as surgery always needed, are there ways to heal this with food and supplements? This I've addressed in detail. You cannot heal endometriosis with food and supplements. There are certainly ways that we support your body with your diet, and an anti-inflammatory diet like the egg quality diet is great for endometriosis. It's really, really good. And there are supplements that we definitely do recommend that are helpful for controlling inflammation and supporting your body in like not growing the endometriosis as fast, but there is no food or supplement that can remove it from your body. Next questions are all from Layla. So there's one that's about the egg quality diet, so I'll answer that one first, and then the other ones are all about medications and IVF. So she says about reintroducing foods after phase 3, the instruction says to try a half portion twice the first day and a full portion twice the next day, and then avoid the food, even if there are no symptoms. So we should avoid the food, even though the reintroduction was successful. If so, until when? So it can take several days, 2 or 3 days average. You know, there are exceptions to that. There might be someone who doesn't see signs for more than 3 days, but I think the vast majority of people should expect 2 or 3 days to be enough. It can take 2 or 3 days for a symptom to arise and for you to identify it in your body and you to be able to link it back to something. So let's say you reintroduce almonds. You have a small portion, right? A half portion twice the first day. And as long as you're okay, then you move on to having a full portion of almonds twice the next day. And then you take 2 or 3 days where you don't have any almonds, and you also don't reintroduce another new food, where you just continue eating the diet of the foods that you ate before you reintroduce the almonds. And as long as during those 2 or 3 days you don't have any symptoms, then you can consider yourself good to eat almonds and you move on to the next food. That's the reintroduction process. If you have any questions about it, you have a symptom come up and you're not entirely sure, was it related to the almonds? Was it not related to the almonds? That 2 or 3 days also gives you like a little bit of pause for everything to return to normal. And then depending on what the symptom was, how severe it was, how likely you think it is that you're reactive to almonds, you have a choice. You can never try the food again, or you can wait until that reaction is gone and then try reintroducing almonds using the exact same procedure again and see if you have that reaction again or if you don't. So now moving on to the last few minutes, we'll talk about some drugs and IVF. So Layla asks, can Omni help with embryo quality? So by this, I believe she means Omnitrope, which is human growth hormone. So egg quality and embryo quality is the big question in the room that is the answers for which are the vaguest, right? So there is no test of egg quality, and embryo quality is unless there's a clear identified male factor, embryo quality is mostly going to be laid at the feet of the egg, laid at the feet of the woman, and just assumed to be about egg quality. Whether that's true or not, but the egg plays a lot bigger role in making an embryo and a person than the sperm does. So, you know, it is at least partially accurate. There is no measurement, there's no test, there is no way to confirm that an egg or an embryo has good quality other than a live birth of a child, which is months and months and months in the future. So anything that we do that improves your responsiveness, improves your ability to make healthy embryos, if you are doing this without IVF, to have a robust ovulation at an appropriate time and to make a proper, healthy, robust amount of progesterone to support pregnancy in the second half of your cycle. If you're doing this with IVF, to have your ovaries be responsive to the medications and to be able to retrieve mature eggs that fertilize and so on and so forth. Anything we do that improves that, in theory, should be improving egg quality, with the exception of just like pumping you full of the highest dose of drugs possible. Dosing of drugs can, and supplements like DHEA, for instance, dosing can swing too far and can start to damage things. But introducing something like Omnitrope, like growth hormone, as on its own, in general, is something that I would say would increase responsiveness, increase potential, and so therefore should, in theory, increase quality. But we can't make a direct connection through like any sort of scientific test. So growth hormone is growth factors, right? Like it's something that is high in our bodies when we are very young, when we are going through a ton of robust growth, and then it decreases and we make less and less of it as adults. So introducing it as a drug is trying to raise the levels back to the level that they would have been when there was a lot of growth happening in your body. And so then the ovaries, which are still growing things, right? You're not growing new bones, but new muscles or whatever. You're just repairing and maintaining what you have. But new eggs are being stimulated to grow every month. So the ovaries should be responsive to the growth factors in the omnitrope. And so that should help them to respond to the other medications that stimulate them to grow. There are some women who have like higher insulin growth factor, where there are some studies that suggest that using human growth hormone in women who have higher insulin growth factor, IGF. I think that's what it's called, insulin growth factor. Let me just, so that I know that I am not, insulin-like growth factor, sorry. It's not insulin growth factor, it's insulin-like growth factor. So if that level is higher in a woman, then maybe omnitrope isn't appropriate and could potentially have some negative effects. Omnitrope can definitely be used in a couple of different ways. It can be used during the cycle along with the stims like gonal F, follistim, menopur, Clomid, etc. It can also be used prior to the cycle when you might be given something like estradiol or birth control for priming. They can also introduce some omnitrope there. So what I would say is, like, if you are looking to increase your responsiveness, omnitrope is certainly something to try. We see a ton of people use it. I haven't seen it have any negative effects. I do know that, more is not always more, full stop. That's always true. So there is a limit to how many things anybody in particular will benefit from. I'm not saying every single person should use as much omnitrope as possible, but it can increase your responsiveness. Now, doing something like PRP, ovarian PRP, is also introducing growth factors directly to the ovaries. These are growth factors that come from your own body as opposed to being a synthetic recreation of a hormone that's in our bodies, right? Because they take your blood and they spin it and they separate out like the red blood cells and things like that. And then they just inject you with the platelets and the plasma, right? That's what it stands for, platelet-rich plasma, PRP. So that the purpose of that, the reason that that works, the benefit of that is that it introduces growth factors to your ovaries. So if you had a high IGF-1 and you couldn't use omnitrope, you could consider ovarian PRP. If you are considering between the two of them, they're not exactly the same, but they will have similar functions. So you can sort of think of them that way. And then the last question is actually a question I've never gotten before. And so I don't know how much most people are going to know about it. Layla asks, what is calcium ionophore for, and could it help with embryo quality? So I'm not going to go into tons of detail on this, but calcium ionophore is you can think of it as a drug, I guess. It's not given to a person. It's given to like a little dish of eggs, basically. So what happens for fertilization to happen is that the sperm is let into the egg, and then fertilization happens inside the confines of the egg. So studies show that the sperm in its little sperm head has something that activates calcium that's inside the egg, and that is part of how it is like allowed in and then allowed to do fertilization. And so when there is a sperm quality issue, we get concerned that the sperm heads are not making enough of this protein, that they're not as effective at using this protein. They're not as good at activating the calcium so that all the fertilization can happen. And so they can use this drug, this calcium ionophore, to do almost like a little marinade, a little wash. So they will kind of soak the eggs in it, allowing them to like absorb more calcium, so that even if the sperm are a little like struggly in their functioning, the amount of calcium that's in the egg is like super robust and like ready to go, and it kind of like takes some of the heat off of the sperm. I think also in theory, maybe there could be situations where a woman's eggs don't make enough calcium or have enough calcium, or whatever it is, and so maybe there are situations where the sperm is not actually having a problem, and using the calcium ionophore like can still improve the fertilization rates. But basically, it's not a drug that you're going to take. It's not a drug that your husband's going to take, your partner's going to take. It is part of the process of what happens in the embryo lab at your fertility clinic. And so it's something that if you are having fertilization challenges, you can ask them about. Do they do it? When did they decide to do it? Why would they decide to do it? Are you a good candidate for it? Will they do it with you? If you aren't having fertilization challenges, like they retrieve, let's just use round numbers, 10 eggs and 9 fertilized, that's like very good, very normal. I don't think you really need to pursue this. But if they retrieve 10 eggs and you only have 5 that fertilize, my like antenna are up. Like, what's going on? I want to understand more about the sperm. I want to understand more about the maturity of the eggs. I want to understand more about stuff. And like, this might be one of the tools that the embryo lab could have in its pocket in order to help improve that fertilization rate in the future. So the question, will it help with with embryo quality, is I think it's unknown. It's a tool that can be used with ICSI. And there's, back and forth on ICSI. Does ICSI, does it really help? It helps to introduce the sperm. They like poke the sperm in to the egg. They don't wait for the egg and the sperm to decide to do that. But does it actually result in more live births or not? I think sometimes the research kind of goes both ways on that. I don't know of any research that suggests that the calcium ionophore is dangerous or like has negative effects. But I think any embryo, any egg that is fertilized creates an embryo, right? How far that embryo develops, and whether it then can be transferred and become a human baby, is a lot of measurement. But certainly if you are having a fertilization challenge, if your eggs are not being fertilized enough, I think that it is another tool to try to increase the number of embryos, and that the number of embryos increased in this way by like maturing eggs in the lab, by using something like ICSI, by using something like this will increase your chances to have a transfer of an embryo that can become a healthy baby. And that's the ultimate measure of embryo quality. So it's not the exact answer you're looking for, but I don't think anybody can answer that so much. So let me just check the chat. Catherine said, thank you. And I already answered Layla's questions. So that is everything. And I hope you guys all have a great week and weekend. And thanks for all the really great questions. And I will talk to you all soon. Bye.